Hello everyone, this is Ed Norton. I'm going to present a topic of moral distress and compassion fatigue in critical care nurses, especially like some warning signs and self-care practices and some relevant concepts related to this topic. So compassion fatigue is a gradual reduction in compassion over time that results from a cumulative and persistent desire to help suffering patients. Compassion fatigue and moral distress, they can result from cumulative exposure to undesirable clinical events, and the rising population of the chronic critically ill will, place a very big strain on clinicians in the coming years. Moral distress is an internal conflict that occurs when nurses are unable to perform accordingly to what they believe to be ethically correct. One of these authors commented that nurses bring themselves to work and everything about them when they come to work. Their morals, their wants, their likes, their dislikes, their mores, their ethics. So it prevents, a conflict at times, and regardless of your setting, your practice and setting, your environment, your management structure, we're still humans taking care of humans. And moral distress is a state that can persist, especially when critical care nurses are unable to act on moral decisions or judgment in practice. And like I said, this cumulative exposure, results in a residue, and it can have lasting effects on us, especially when we're exposed to human suffering, chronic critical illness, things like, prolonged mechanical ventilation and things like that. So there's a very big warning, that's coming, and the United States Census Bureau tells us that the current population of people who are 65 or older will grow to almost 19% of the total population by 2030. And this is the group that tends to experience chronic critical illness more than any other age group. And it's just going to grow, 19 million people by the year 2050, that are 70 years or older. In between the years 2030 and 2050, people who are 85 or older will account for about 4.3% of the population. And as, technology grows and we become supposedly better at taking care of people, this is going to present more and more exposure to, human suffering and difficulty in achieving quality and meaningful outcomes of care, especially in light of the nursing shortage. Epidemiology of chronic critical care illness. Kahn, conducted a study of patients in 5 states who were chronically ill, and found that the prevalence of chronic illness, is based on a consensus definition, is substantial and it's just getting bigger, with over 100,000 in-hospital deaths. And I think this study had probably about like 300,000 people. And they found that, the incidence of chronic critical care illness increases with age, and the 1-year mortality can reach as high as about 50%. And remember, like I said, the population is aging, so we're going to be facing this more and more. Tano and his friends found that patients who were 65 or older had an increased incidence of ICU admission, and by as much as 30%, with a little more than a third of them having 3 or more returns to the ICU in the last 90 days of their lives. Keep in mind, like I said, the population's getting older, and the last 3 months of people's lives are spent, in a setting like in an acute care hospital. These authors, they're near and dear to my heart. They're attendings that practice in my institution, Dameworth and others. They reviewed studies in like 16 different countries, and they ended up reviewing about 126 studies with over 300,000 patients in them who had chronic critical illness and prolonged mechanical ventilation. And a consensus definition of prolonged ventilation is only as far as 96 hours. So in acute care and post-acute settings, they found that the United States fares worse in regard to this number, and our pooled mortality is as high as 73%. As this population is followed over a 2 to 4 year period, you see that the remaining survivors, 70% of them will die over 2 to 4 years, and only 18%, if they're lucky enough, are ever discharged to home, and half die within 1 year, especially in the setting of prolonged mechanical ventilation or end-of-life issues. Clinicians, tend to express in qualitative studies, and that people they find, that they care for, don't really have much quality of life, at the end of their hospitalization, and sometimes they're discharged in severely compromised states that some people might perceive to be worse. So who's at risk? People like us who are pursuing advanced degrees, advanced practice roles, like we're 18% more likely to experience post-traumatic stress disorder and experiencing settings such as this that, you know, expose us to, uh, the chronically ill and the people who are, have more difficulty in being liberated from the ventilator. And just as a side, some of that chronic critical care illness, can cost anywhere between 25 and 35 billion dollars a year just in the United States. 25 alone, and if you want to count post-acute care, subacute rehab, long-term, care facilities, and vent-dependent facilities, you're looking at $35 billion a year to care for this population. So as we become more educated and we have higher degrees, the higher level of moral distress, especially in the ICU. Length of experience. It's found that nurses with 10 or more years of experience showed a higher levels of distress, and a lot of that was due to a dose response. As I said, they describe this residue that we accumulate when we're exposed to situations that promote, moral distress or erode our ability to properly provide care and be compassionate. Age. People tend to find that younger nurses are more likely to develop secondary post-traumatic stress. Older nurses, seem to have more professional and life experience, and they found that, even people who have children, it seems to be a protective quality that they have that life experience and professional experience that seem to help them cope with the challenges of critical care nursing and to see that they have, the ability to really take care of themselves. So there's emotional and intellectual signs to look out for in your colleagues and yourself. And a lot of these are synonymous, I think, with post-traumatic stress disorder. You have anger, flashbacks and irritability. You feel overwhelmed and hopeless in the face of all this suffering. And then you may see somebody on the other end who is just totally apathetic, cynical, and use sarcasm to deal with, this kind of adversity. People may relate that they have dreams about these things. Intellectually, you may just not be getting anything intellectually out of your practice environment. You may become bored, you can't concentrate, you're disorderly in your work, and you have a hard time paying attention to details, especially, learning new information, exposing yourself to new learning experiences, and conflicting loyalties. Because like I said, some of this moral distress and this compassion fatigue results and the influence of outside forces that we just don't seem to have much control over. So we got to take care of ourselves. All right, so we take care of our basic needs. We sleep, we exercise, we cultivate our relationships with our peers, eat well, participate in hobbies, like just an overall commitment to self-well-being. We cultivate strategies to stabilize our attention and affect, and we create a zone of resilience. Prepare yourself before you encounter and interact with your families and your patients. Make sure that you take a deep breath, internalize what you're about to see and interact with, and think about it, and just try not to have a knee-jerk reaction. Pay attention to your body. Monitor those somatic responses. Be aware that if you're having just stiffness in your joints, that headache, that neck pain, ground yourself, prepare yourself. Listen to what your body is telling you so that way you can take care of what it is that you need to take care of. You want to develop insight to distinguish self from other. You want to make sure that you understand that you are not your patient. Your personal experiences and your wants and your dislikes and your things, all those things are not your patients. They're not your families. That they're yours and yours alone. And, these authors that talk about the framework for understanding moral distress, Rushton and his friends, they say that like over-identification can cause a loss of boundaries, and you don't want to do that. You want to make sure that you distinguish yourself from others. You want to practice mindfulness. You want to make sure that, you things like acupuncture, spinal manipulation, massage therapy, yoga, tai chi, learn a new instrument, things that are mindfulness-based stress reduction tend to like improve your physical and emotional health, help reduce that work-related distress among you, and really help you take care of yourself and decompress. You want to recognize empathetic overarousal and personal distress. All right, you don't want to allow like your previous experiences with similar, situations and similar presentations of of illness that have you seen in the past. Like I said, some of this does refer to post-traumatic stress disorder. So you got to make sure that like you're paying attention. Are you experiencing aversion to certain situations? Are you freezing? You're anxious? Are you experiencing a fight or flight kind of response? Watch your somatic responses. Like are you getting headaches and aches and pains? Do you feel depressed? Are you having dreams? Are you having situations where maybe you just don't feel right? Develop methods to foster reflection and inquiry. Develop your peer support systems. Develop your relationships, and make sure that you have people around you who can help you and you help others to see that maybe if your response is just not appropriate to the situation, it's out of proportion. Make sure that you keep the clear, boundaries of responsibility. You're responsible for delivering the care. You may not necessarily be responsible for the choices. Factors, foster systems that address ethical concerns and dilemmas. You want to find out, like there's a way, involve the ethics committee. Develop institutional policies yourselves and support yourselves in the face of ethical dilemmas. Mental health, spiritual health, ethical health, all those things are, could be cultivated by yourself, and make sure that you take that. You want to examine the qualities of your practice area. Find out what it is that precipitates these moral dilemmas. What is it that causes these things to happen? Are there common themes? Are there instances where these things could be avoided? So you just need to make sure that you do the best you can and you take care of yourself. Lots of future research to be done on this. I hope everyone takes a little bit about this, finds a way of taking care of themselves. Like a friend of mine once said, the heart feeds itself first. So if you take care of yourself, if you practice, this mindfulness, you practice the framework of self-care under the framework of understanding moral distress. Couple that with Watson's theory of human caring, and what that theory says, we have to take care of ourselves first in order to be able to take care of others. I wish you well. Have a great summer.